In today's video, we're going over evidence-based treatments for patellar and quadriceps tendinopathy. What's going on, everybody? This is Dan Pope and Kevin Coughlin. We are physical therapists. We go through that literature that's such a big pain in the butt. We summarize it. We give you the good stuff. We give a little bit of clinical practice with it just to show what we find with these conditions. It's amazing. What do you think, Kevin?
Dude, I'm very excited about this episode today. This is a Dan Pope special. So,
Dude.
Teach me, man. I'm ready.
Okay. Well, I'm super excited. I did a lit review a few years ago, and I've updated it recently, and I learned some new stuff, and I'm excited to share that with you guys. So what are we going over today? Let's summarize what you're going to learn. It's going to be great. So, of course, we're talking about treatments today, and we're going to give you an evidence summary. We're going to talk a little bit about patient education, what you should tell your patients. We're going to talk about exercise, mostly, and all different types. So eccentrics, isometrics, heavy slow loads, blood flow restriction, progressive tendon loading, and movement modification. My gosh, there's so many different types of exercises. Which are the best? What should you use? What does evidence say? We'll talk a little bit about activity modification. So this is load management, obviously very popular right now, and as well as some jump retraining. We'll see if that's important or not. And we'll talk about some funky things you see sometimes. So if your patient's not getting better, or if you want to try to get them better faster, improve their outcomes, should you consider things like shockwave therapy, using a strap over the knee? How about surgery? Who should get surgery, and is surgery effective at all? You ready for this, Kevin?
Dude, I'm excited. Right now, all I do is surgery. So I like to do some other things for my patients.
Yeah. Well, surgery is, good stuff. Just chop it off if it hurts, right?
Yep.
Sorry, that was a bad joke. All right. Let's start off with good old patient education. I think this is probably going to be the first thing that you talk to your patient about. And I've said this in prior podcasts, but I think patient education may be the most powerful thing you can do with your patients. So there is some research to help guide us. For a lot of these papers, they included patient education with exercises. So again, we're not really sure if it's the education that's most powerful or if it's the exercises, so on and so forth. But they're probably both important, right? And this is coming from a research paper called The Effectiveness of Progressive Tendon Loading Exercise Therapy in Patients with Patellar Tendinopathy. Breda was the lead author. And I think this was a great paper. We'll go over this a little bit later, but it's basically laid out in the way that most folks would do their physical therapy for patients that have patellar tendinopathy. And they utilize some patient education. And some of the things they went over were an explanation of the condition. Essentially, what is patellar tendinopathy? What is the expected management? So essentially, exercise is good for you, right? They talked about that positive influence of exercise therapy. They also talked about the positive effects of a gradual return to sports. So we don't want to go from 0 to hero, right? That big spike in training volume can cause problems. And they also used the pain monitoring model to figure out the progression of exercises. And it was kind of interesting because they were comparing this progressive tendon loading program with an eccentric program, which we have long considered a gold standard, although in more recent years, we know that eccentrics are not necessarily a gold standard. A lot of different things work well. And essentially, they were allowing 3 out of 10 or less pain during exercises, whereas in the eccentric group, they actually allowed 5 out of 10. So allowing more pain, maybe not beneficial. Who knows? But I'll give you the results of that later. But just basically telling patients what's okay and what is not okay is important. Pardon the interruption, but I have something that's going to change your life. It's $1 million. No, it's not. But it's an evidence-based guide to patellar tendinopathy. Staying on top of literature is hard. It never feels good to have a patient in front of you with a specific condition and you haven't read through the research recently. Well, this bad boy is going to help you out. It is an evidence-based cheat sheet for patellar tendinopathy, and my promise to you is I'm going to catch you up to date with the literature on patellar tendinopathy under 10 minutes. We go over definitions, anatomy and biomechanics, differential diagnosis, risk factors, prevalence, clinical presentation, recurrence rates, how to diagnose this condition, and all the best treatments for this common problem. Best of all, it's 100% free, so go ahead and click on that link in the show notes in the description and get your cheat sheet on how to best treat patellar tendinopathy. Now back to your video. So first, we'll go over exercise. I think it's important to understand that all forms of exercise are beneficial, right? And this is coming from an article in 2018 where they're basically trying to figure out which types of exercises are going to be best, right? And again, this is 4 or 6 years old at this point, so there's been some more research coming out. more recently we'll talk about. But essentially, you can use eccentrics, which is using the lowering portion only. So think about a squat, doing something like a single-legged squat on the way down and then a double-legged squat on the way up. So you're really overloading that lowering portion. So isotonics have also been shown to be helpful. So that's the addition of the concentric portion. So basically doing a squat and going up and down together. Heavy slow loads have also been shown to be effective. So basically that's using isotonics, but using a tempo, something like 4 seconds on the kind of raising phase, 4 seconds on the way down, and then progressively loading that from like a 12 rep max to a 6 rep max. It's also research show that isometrics are effective for tendon pain. So essentially doing something like an isometric knee extension against the wall. And they've been shown to be effective in the short and long term, although the research in the short term is a little bit more powerful, right? And we'll talk about that research in a little bit. But there's no gold standard really in terms of which treatments are best. You can probably use a variety of different types of exercise, and it can be effective. And what's kind of nice is that you can choose what's best for the patient in front of you. If you have an in-season basketball athlete, you're probably not going to do as much kind of heavy, fast loading with that person. Probably want to slow things down, maybe more isometrics, maybe more blood flow restriction training, be more beneficial for that person. If you give them like a heavy eccentric program, you might just make it worse, right? So we can choose what's best for the patient that's in front of us. Any thoughts on that, Kevin?
Yeah, I think that's one of the best parts, like you had just said, is that we have options. And I think that the way I've looked at it in the past is that all the options work. But I think what you've said is kind of what I find now is that there's probably something that works for everybody. But what works, for someone at one point in time is going to be different. So, I could have 3 people with patellar tendinopathy, and maybe one of them just seems to do really well with heavy, slow loading. And one of them does really well with eccentrics, and the other one is, so flared up, they're only tolerating isometrics. So, any of those options are fine, and you could play around with which one's going to work for the person in front of you. And I think it's good to know that most of these different loading protocols are going to be helpful. So, if you try one, don't freak out. And if it's not working, try one of the other ones. And some people really find that they like a certain protocol, right? So I have a guy who he loves loading the quad machine, and he loves doing it with heavy, slow tempo. And he just feels like that really gets his quad going. It doesn't bother his tendon at all. Versus we were trying like rear foot elevated split squat with the slow lowering. And when that was the back leg, it really just kind of flared it up. So you can get creative here and find what works best for the person in front of you, which is pretty cool.
Yeah, and we'll talk about another paper a bit later that kind of emphasized your point here. But essentially, we can use what we want. And if we use something the patient likes and enjoys, they're probably more likely to do it, probably have higher patient satisfaction and less pain. And all those things are a positive. So I would say that you can be a little bit more pointed, and you may actually have a better outcome simply because the patient's more likely to do it. They like it. They believe in it more. All those things can be really positive. All right, Kevin, how about heavy loads versus moderate load? I have heard that you need to load the tendon heavy in order to make a change. Is this true?
Dude, that's what I've been telling people. So let's see.
We'll see, man.
We'll see.
So this was an article, American Journal of Sports Medicine, 2021. They looked at that. So basically, folks with patellar tendinopathy, and they're given a protocol of heavier loading versus moderate loading. And this was 44 adults. Essentially, the heavy group was using 90% of the 1 rep max, which is indeed heavy. And the moderate group was using 55% of 1 rep max. And if you look at broadly through strength training literature, usually that number that people start on to start building strength is 60% or greater. So they're actually just below that. So I do think it was kind of a moderate load group. And the outcome measures they had were the VISA-P, pain scale. And they were also looking at pain during running, squats, playing sports. And they also had ultrasound findings, which are cool. They're just basically tracking the tendon to see if the changes are different from group to group over the course of time. Lo and behold, what do you think they found there, Kevin?
I can't wait to hear.
Same outcome and both beneficial. Two things. I think you see this in other literature as well. So the rotator cuff is one of those. My criticism for those studies are that usually rotator cuff folks are sedentary, right? So it might not matter. They're not trying to get back to anything heavy. But for folks that have patellar tendinopathy, they're usually trying to get back to basketball, volleyball, so on and so forth. So I would think heavier loading would be more important to make that tendon more robust. This study didn't show that. So I think that's just important to keep in mind, is that there's this idea floats around, you need heavy loads to make a change, and it's going to be a superior outcome. At least this study didn't show that. Obviously, it's only 44 people, one study, but you're starting to see this a little bit more across different tendon pathologies. So just an interesting thing to note. All right, Kevin, isometrics. Should we use isometrics? Yes or no?
Definitely should use them.
Definitely. All right. Well, let's delve into this literature, shall we? This study right here, I think, is what started off isometrics with a bang, especially in the patellar tendon. This was researched by Ebony Rio. The title of the article is Isometric Exercise Induces Analgesia and Reduces Inhibition in Patellar Tendinopathy. Very, very cool study. Essentially, they had a few volleyball players. It wasn't very many. I want to say it was like 6 or 7 volleyball players. And they basically had them do a single-legged step-down task and ask how much their pain was before and then after applying these isometrics immediately afterwards. And then after, I think they did 60 minutes afterwards, they kept on testing these step-down to see if the changes would stick around. They performed 5 sets of 45 seconds of an isometric knee extension. And they used 70% of the MVIC. So they put electrodes on the quad to see how much electrical activity was going through the quad, had them push to 70%. Obviously, you can't reproduce this easily in a clinic. I tell my patients just do 70% of their perceived max. And guess what they found in this study here, Kevin?
This finding is always fascinating to me. It's crazy.
Yeah, it's crazy. So essentially, the isometrics worked very, very well. On average, these folks had a 7 out of 10 pain with a step down. And after the intervention, they were 0.17 out of 10 pain. So less than a 1 out of 10, almost a 0 out of 10 pain-wise. And what's really cool is that this was maintained for 45 minutes. And in the isometrics group, they had the added benefit of reduced cortical inhibition. One of the things that happens in tendinopathies, and the way it was described to me, which makes a little bit of sense, is when you have tendinopathy that's symptomatic, it's kind of like you have a teenager learning to drive and they have one foot on the gas pedal, one foot on the brake. They're essentially slamming the gas, slamming the brake, slamming the gas, slamming the brake. Kind of the same thing happens with a tendon with tendinopathy. And we believe this has to do somewhat with the reduced cortical inhibition. And the isometrics actually improve that better than just doing isotonics. Here's a little caveat. They also improved isotonics in this study. So essentially, they just did knee extensions. And they actually worked really well, just not quite as well as isometrics. What I will say, we won't go into all this literature. A lot of folks have tried to reproduce the same exact study in multiple tendons across the body, and most have not been effective. So essentially, what they showed is that isometrics and isotonics were kind of equally effective in reducing pain, although Ebony Rio obviously found that the isometrics were a bit better. So you can probably use both for your patients. At the end of the day, use what works a bit better, right? You don't have to choose one or the other necessarily. You choose the one that works the best. What do you think, Kevin?
Yeah, I think just a couple quick points on the last slide. You talked about the heavy, slow resistance versus the moderate loads. So heavy loads versus moderate loads. And I kind of agree with you. I tend to be using heavier loads because it more closely aligns with my patient's goals, right? They have to lift heavy. But that is cool to know. I definitely wasn't aware of that. I've been using the reps in reserve type model where we're trying to get like 1 to 3 reps in reserve to, I thought, elicit tendon changes. But it is cool that they looked at the tendon with the ultrasound and there were no differences. So I think in terms of managing tendons, that continues to give us more flexibility with what we do with people. We can find what works best for the person in front of us. And if you do have someone who's sedentary, who's going to be a lot more comfortable lifting, 55% of their 1 rep max, then that's a great option. And then just in terms of the isometric study, I remember you saying that to me, maybe a year or so ago, is that even though those results were really impressive, right, it hasn't been replicated. And anecdotally, I would say I don't tend to get a huge benefit with isometrics with my patients. I don't find that I have a massive reduction in pain because I know we're going to get back to isotonic loading anyway. And I find that just with like a good warm up, the pain tends to be reduced a little bit. And like you said, sometimes with just knee extension, where you're actually moving in the knee extension machine, sometimes people have a reduction in pain. So because I don't utilize isometrics much in my own or my patients' training programs as an end goal, I don't tend to use it very often in rehab. That's just my personal treatment approach right now. But, I think if all else fails, it's something we could try. And there is at least this study with a pretty stellar cast of authors on that paper showing that it could be helpful for some people. But I haven't been using it a ton. And I find that if we're doing it for the pain anyway, there's other ways it seems like that pain can be reduced through different types of warm-ups. And that's just my anecdote there.
Yeah, that's my bias too. I think I may have even told you this as well, is that if I can skip the isometric stage, why wouldn't I? Because I'm getting closer back to the activities that the individual wants to, get back to. My bias has been a little bit challenged from the progressive tendon loading paper that we'll talk about in a minute. But yeah, my thought is like, hey, if we can get back to heavier loading more quickly, faster movements more quickly, why wouldn't we? That's closer to their goals, right? The other piece that is important to keep in mind is that as physical therapists, we're also thinking about other things besides just kind of pain and the outcome of getting back to sport, although that is usually the priority. We also want to try to improve their performance, improve their strength. If we're doing low loads, we know that's not going to be as good for improving strength, right? So if anything, I might choose that higher load if the patient tolerates it well. That's a big caveat because oftentimes they don't, because I know that's going to build their strength more, right? And anytime that I can hit two birds with one stone, I am a murderer of birds. I'm trying to improve someone's performance and I'm trying to reduce their pain at the same time, almost always. So in terms of moderate loads, hey, we'll use it if we need to, but otherwise I would probably rather go a little heavier. What are your thoughts on killing birds? Any thoughts before we move on?
That got me pretty good, especially
Yeah.
because I know your t-shirt of birds are really government spies. So government's gonna be pretty mad. Keep killing birds, dude.
Yeah. So just so people know, no birds were killed in the making of this podcast. I'm actually a big bird fan. That's one of the reasons I know I'm getting older is because I'm watching birds. I'll see like a hawk and everything stops. I'm like, whoa, did you see that hawk? I'm just enamored. So yeah, no birds were injured in the making of this podcast. Let's get on to the patellar tendon. So the next question that I had was, are isometrics good for longer term outcomes? Because we just showed they can be really beneficial in the short term. What about if we introduce some isometrics, do it for a few weeks? Does that actually help longer term with individuals with pain? And this was another study with Ebony Rio called Isometric Contractions Are More Analgesic Than Isotonic Contractions for Patellar Tendon Pain, an in-season randomized control trial. So they're looking at isometrics versus isotonics in season. They had volleyball and basketball players. Group 1 had 45-second isometric contractions, 60 degrees. Same basic study parameters for the most part as in the prior study. And group 2 just did 8 rep max knee extensions, 80% of 1 rep max. And they basically performed these 4 times a week for 4 weeks. And they showed that both were effective. However, the isometrics were more effective for pain relief, right? And personal bias, I don't know if this is the reason why. Essentially, they were doing this in season. And those tendons are taking a beating. And we do kind of heavier knee extensions. Maybe that's too much. I don't know. Isometrics might be that nice step back in season that allows you to progress a bit better. Again, this is Ebony Rio. I'm not sure why, but anytime she's on the paper, it seems like the isometrics do a little better than the isotonics. But at least in this study, that's what they showed. So interesting stuff. Anything else to add about the isometrics before we move on?
Yeah, I think, like you said, I'd like to see it replicated a little bit more. But if it helps and you're not getting those results with other things, it's definitely something to try. And I think I'd probably do what they did in the study for a protocol, because if it worked there, you'd want to replicate that as best as you can. I just find that it even takes quite a bit of time to like set up and do. It's a lot of time. It's pretty boring. And I don't like doing isometrics, but again, it's a good option that we can try. And perhaps in season, like you said, their training volume might be so high that they're not tolerating lifting 4 days a week. And maybe this is something that allows them to keep playing. So use the research and try it and see if you get, good results.
If you guys like what you're learning about so far, then the next logical step is to sign up for the Fitness Pain-Free mini course. I've made an absolutely free mini course, and we go over 4 vital lessons for coaches and clinicians. The first lesson goes over how traditional schooling has failed us. Now, I'm actually a really big fan of education, and I think that physical therapy school actually prepared me pretty well to work with the average person. However, I really didn't learn how to work with the population that I want, which is people in the strength and fitness world. So I'm talking about powerlifting, bodybuilding, Olympic weightlifting, sport of fitness, and really people that just love working hard in the gym. And really my goal with the mini course is to help you understand how you work with this population to get them out of pain and keep them training. The next lesson is 7 reasons why people get hurt in the gym. So it's vitally important they understand the injury mechanisms or why people get hurt in the gym. If we don't understand why folks are getting hurt in the gym, it's going to be very hard to rehabilitate those folks, because let's say we do get them better, they go right back in the gym and get hurt in the same exact way they hurt before. The other piece is, if we want to keep these folks safe for the long haul, we have to understand the main reason why these folks get hurt in the first place, so we can keep them in the gym training as safe as possible and minimize that risk of future injury. Next, we go over 4 simple steps for getting your clients out of pain. Now, rehab can be very complicated. There's a lot of systems out there that make it very challenging to figure out how to work with your patients. However, it really doesn't have to be that complicated. So I go over 4 easy steps you can follow to get your patients out of pain and back in the gym where they belong. Lesson number 4 is how to build the career of your dreams and earn the respect of your community. Let's face it, the reason why you take these educational courses is obviously so you can learn a little bit more, but really the deep-seated reason is because you want to have the respect of your community. You want your clients to come in, work with you, and say, wow, Joe was great. He did a phenomenal job with me. Tell their friends, and their friends come to see you. And after a while, you're very valued and respected within your community. So I'm going to teach you how to do that. The second piece is that if you know these skills, it doesn't always mean you have a ton of patients going through the door so you can work with the population you want to work with, right? So you may be the absolute best coach in the world, but no one wants to come and see you because they don't know who you are and they don't know how good you actually are. So we'll teach you how to get the patients through the door that you want to work with. And lastly, we'll talk a little bit about the Fitness Pain-Free certification. This is the largest and most comprehensive educational course that I offer, but more on this later. So I'll leave a link in the description, in the show notes. Again, it's 100% free, really easy to download. Go ahead and do that right now. Well said there, Kevin. Next, blood flow restriction training. Do you think it's beneficial to restrict most of your blood flow to your legs exercise? Sounds crazy, but does that help folks with patellar tendinopathy, Kevin?
I usually restrict 103%, but
so the blood kind of goes backwards kind of thing?
Yeah. Yep.
Tries to go to the legs and gets forcibly, I don't know, redirected 3% the other way, something like that?
Yeah, they're still trying to work out how that happens, but
Good. All right. So blood flow restriction, is it beneficial for athletes in season? Well, we have a study here. So this was in Med Science Sports Exercise 2022. Low load blood flow restriction, high load resistance training induced comparable changes in patellar tendon properties. So essentially, I have a couple different articles here showing that BFR training is beneficial for patients that have patellar tendinopathy. First of which, Cuttaford in 2020, IGSPT. 2 in-season decathletes that had success with BFR. Sentner et al. In 2022. They looked at BFR versus regular loading 3 times a week, 14 weeks. And what they found essentially was that the mechanical tendon properties and strength changes were similar between groups. So both had a positive benefit, and the benefit was the same. And that was pretty cool. That was actually the first article I mentioned. I kind of threw a curveball there and screwed with the ordering there. But pretty cool, because what they're showing is that BFR is going to be equally beneficial for reducing pain, improving outcomes, right? Also improving strength, which is what we talked about before in terms of moderate versus high load, right? And they also found that mechanical tendon properties had a similar improvement. So again, that thought is you got to put high loads through a tendon to see those mechanical changes. Maybe not the case. And you can actually get it with closer to 20 to 30% of your 1 rep max if you use BFR. If you haven't worked with very many patellar tendon patients, usually these folks don't tolerate heavy loads, right? So all this fun stuff like I don't know, single-legged heel taps, decline, slant board, squats, heavy loading via leg press, split squats, step-ups tend not to be tolerated very well, especially in the early stages of rehab, and particularly in in-season athletes because they're already getting that patellar tendon hammered by sport. So blood flow restriction is really nice for these folks, and it seems like at the very least it's giving very similar improvements in strength and performance, as well as those mechanical properties and pain, so on and so forth. And again, Burton et al. In 2022, basically their conclusion was BFR is encouraging, but we need more research, which is what every single research paper shows. But keep in mind, a lot of these studies are smaller sample sizes, not a lot of athletes. We probably do need more research. Can't hang our hats on just a couple studies. Any thoughts on that, Kevin? Do you use BFR much with your patients with patellar tendinopathy?
Yeah, totally. I think if someone's too irritated, they're in too much pain to tolerate what I usually use, which would be heavy, slow resistance training. I find that instead of going to isometrics, I tend to go to BFR. I guess it's just our patient population. They're used to training a lot and they want a kind of good workout. They want to feel like they did some work. And a lot of times you can do more simple movements at a lighter load with blood flow restriction. And they kind of get those benefits and they feel like they had a good training session without the tendon pain. So I guess the limitation there is that they need access to the cuffs and it's not something they can usually do on their own, but it is a nice thing that they can do with you in the clinic. And it's definitely something I'll utilize for that first stage and then kind of progress as we can to more kind of regular lifting without the BFR.
Yeah, I think that's really smart. One of the biggest issues for athletes, we talk about this a lot, but these folks, their life oftentimes revolves around their sport. And once they can't play their sport, they have an identity crisis, right? And they're really having a tough time from a psychological standpoint. If you can put some BFR cuffs on them, have them do a whole bunch of exercises with minimal to no pain, have them feel like they're able to work out again, you get a huge psychological boost. And even if the outcome is going to be exactly the same as doing isometrics against the wall, athlete's probably going to be pretty excited about what they're able to do and a little less down in the dumps afterwards. Again, total anecdote, but I see athletes that are super pumped after a BFR session, so excited they can actually train a little bit. So I think that's a really good point there, Kevin. All right, now the paper I've been talking about all episode, which I haven't really given you the deets yet, we're going to spill them right here. We're going to talk about progressive tendon loading. At least in my mind, this is the new kid on the block in terms of treatments for patellar tendinopathy. I feel like every few years we're changing our treatment for patellar tendinopathy. This is kind of the newer one. But I will say it was a great study and has changed the way I think about loading my patients with patellar tendinopathy. The study is called The Effectiveness of Progressive Tendon Loading Exercise Therapy in patients with patellar tendinopathy, a randomized clinical trial, lead author Breda et al. And essentially they had 76 patients with patellar tendinopathy, mean age 24 years old, which is good if you're working with an athletic population. I think this kind of reflects that. Younger athletic folks. They were required to play sports at least 3 times per week to be included in the study. And what's kind of cool is that they had an average symptom duration of around 2 years, and 82% of the patients included in the study had failed prior treatment. So I think you're looking at pretty recalcitrant patients that have tried a lot of stuff that hasn't worked particularly well. So, spoiler alert, this type of loading was effective for these folks generally. So I think this is pretty interesting. Maybe it does show you that a more systematic approach might be better for these folks. But again, just kind of guessing. And they had an experimental group that used progressive tendon loading. We'll talk about what that is in a minute. And the control group used what is sometimes called the gold standard for treatment of tendinopathy, but they had an eccentric group, right? So their experimental group was the progressive tendon loading. Their control group was not like a sham or nothing. It was essentially another form of exercise we know that has been shown to be beneficial. So I wanted to see if the progressive tendon loading was better, right? They had a 24-week follow-up essentially to see which group won. What do you think, Kevin? Before we move on, who won?
I'm going to go with progressive tendon loading.
Ooh, okay. We'll see. So let's take a look at these exercises. If you are listening to this, I apologize. Maybe head over to YouTube at some point so you can see what's going on here. But in the eccentric exercise group, they had a few stages, 3 of them. Essentially, stage 1 was a single leg decline squat, kind of that classic exercise you see all the time for folks who have patellar tendinopathy. Stage 2, stage 1, they started with body weight and they started to work their way up with weight. Okay, over the course of time. And then stage 2, they applied some sport-specific exercises. And lastly, return to sport. So it's not like they did only eccentrics. They kind of progressively loaded the patellar tendon with eccentrics. And then they went to sport-specific exercises. And then they went return to sport, right? In the progressive tendon loading group, they started stage 1 with isometrics. So they didn't move with isotonics in the early stages. They focused on isometrics. In stage 2, they did isotonics. And that's things like leg press, things like split squats, so on and so forth. They had a stage 3, which was energy storage or explosive exercises. So they threw in some plyometrics at the end of stage 1, stage 2. Stage 4, they did sport-specific exercises. And lastly, they returned to sports. So much more progressive in nature, starting with no movement and then kind of starting to load a little bit. And then they went into plyometrics. And lastly, they did their sport-specific exercises before returning to sports. Still going with progressive tendon loading?
Definitely.
It's confident. It's very confident. Yeah. All right, let's see the results. Outcomes. How about return to sport? And essentially, we're looking at return to sport at the pre-injury level, okay? So folks that felt they returned back to the sport at their pre-injury level, keep in mind, these guys have had pain for 2 years. So basically at the level they were prior to this injury starting. In the progressive tendon loading group, 43% of those athletes felt like they returned to sport at the pre-injury level, right? With the eccentric group, that was only 27%. So Kevin, you were right here. How about patient satisfaction? At 24 weeks, the progressive tendon loading, their outcome of a good satisfaction was 81%. For the eccentrics, it was actually 83%. So they were about the same from a satisfaction standpoint from the good standpoint. So essentially, I'm not really doing a good job of describing this, but they'll ask the patients what their satisfaction level is at the end of going through the loading. Bad, good, and excellent. And what they found is about the same good response between the two groups. However, 38% of folks in the progressive tendon loading group had an excellent satisfaction, whereas this was only 10% in the eccentric group, right? From an outcome perspective standpoint, using the Visa P, progressive tendon loading was an 84, whereas the eccentrics on average was 75. And the last piece where progressive tendon loading was a bit better is that exercise were significantly less painful to perform in the patellar tendon loading group, with an average VAS scale of 2 out of 10 compared to 4 out of 10 in the eccentrics group. So felt a little bit better to do isometrics and slowly ramp up as opposed to jumping straight into very challenging patellar tendon exercises. So good job there, Kevin. I think overall you were right. Any thoughts on this paper?
Yeah, it's pretty cool. I think that's, kind of the way I think we tend to structure our training programs is thinking of what's the return to sport phase look like, and then work backwards from there. Like I had said, with the caveat of usually instead of isometrics, I'll start with blood flow restriction or something like that, and then progressing to the return to sport phase. Interesting though, either way you cut it, like the progressive tendon loading group, 24 weeks, I think it said 43% return to prior level. So I think that just goes back to, and it did say, right, these were patients who had failed other treatments. So these might be more intense patellar tendon pain. But I think it goes back to just educating our patients on realistic timelines, and that this could take a while, but hopefully you can get your patients back a little bit quicker. But I think it does show that if you did fail other treatments and you've been dealing with this for a long time, a quick fix is unlikely for this, and the patient shouldn't get discouraged by that. It's just, you got to keep training this over time. So that's kind of what I took away from that.
Yeah, for sure. Another takeaway for me is that maybe those isometrics are important. Maybe that's one of the reasons why people do better. Just to keep in mind, I'm going to link to this video in the show notes, but I basically did a video on a very new research study, which was trying to quantify strain through the patellar tendon with different rehab exercises. And they were looking at things like running, cutting, jumping, changing direction. And the exercise that put the most strain through the patellar tendon was a single-legged decline squat, right? More than running, cutting, jumping, changing direction. So at least in my mind, if you go straight to eccentrics, that's like going to the very hardest exercise first. And if you've ever worked with someone that has patellar tendinopathy, you'll probably know that that doesn't work well. And that's probably the reason why they had to have the pain at a 5 out of 10, simply because that's going to hurt a bunch. And I almost never start, unless someone is really mildly irritated, I almost never start with that single-legged squat on a slant board. That's just, I don't know. That's like putting a blowtorch straight on that patellar tendon from the beginning. So that might be one of the reasons why they didn't do quite as well. But one of the things I do a little bit more in my treatment now is that if someone is really irritable, I will consider more isometrics. And I usually will include isometrics at least in my warm-up for a few sets. And I have found that to be beneficial, although I'm not sure it's actually needed. But this study kind of changed my mind a little bit when I read through it.
Hey friend, if you're liking this content, I have something I think that you're really going to love. And that would be a master course on rotator cuff related pain and rotator cuff tears. Having the patient come through the door and you don't know how to treat their pathology, that stinks. You feel like a fraud, you're just making stuff up, it's not good stuff. It's also pretty dang tough staying on top of all the literature that's coming out all the time. Well, guess what? I have done this for you by making a master course on rotator cuff related pain. Well, what kind of stuff do you go over in this course? I've got an evidence-based guide. We go over diagnosis and special tests, my favorite beginner, intermediate, and advanced exercises, how to modify your patient's training in the gym so they can keep on working towards their goals and not hurt themselves more, my favorite evidence-based manual therapy techniques for these folks, case studies on how to treat non-op and post-op patients, as well as the exact rotator cuff related pain protocol that I give to my patients when they come to see me with this common issue. Now that sounds pretty good, Dan, but how much does this cost? How does $1 sound? Whoa, $1? That sounds crazy. Why is it so cheap? It's mostly because I don't know how to run a business, but I do know about the rotator cuff, and I'll teach you all about that. This all comes with a subscription to Fitness Pain for Insiders. It's $1 for 1 week trial and $25 per month afterwards. However, you can cancel at any time. If you don't like it within the first 7 days, just tell me. I will cancel and refund for you. Plus, I have a lot of other really good courses in there as well. We have master courses for cervical radiculopathy, lumbar radicular pain, lateral ankle sprains, and what I'm working on next is, you guessed it, your favorite, shoulder instability. So click on that link in the description. It's $1. Go ahead and get started, and I'll see you on the inside.
So I kind of alluded to this. There's a study by Baxter et al. I think it was 2023, but they basically went through all the most common rehab exercises for the Achilles tendon, and they just ranked them in terms of strain on the Achilles. So they did the same exact thing with the patellar tendon. Baxter was one of the authors, but the lead author was Rodrigo Scatone Silva. And this was in 2024. And essentially they use motion capture and force plate technology to rank exercises from easy to hard on the patellar tendon. And they use a combination of different kind of ways to measure this. So loading peak, rate, and impulse. So loading peak essentially is like how much total max strain is on the tendon during the exercise, right? The rate is how fast is that applied. We talked a little bit about that in the last podcast episode, link in the show notes. Generally speaking, the faster the rate is, the more strain or pain you're probably going to be placing on the tendon. And also impulse, right? So impulse is kind of how long is the force being applied. So if I do like a slow Spanish squat, I actually have a long impulse because I'm putting strain through that tendon for a longer period of time. Whereas if I do a jump, it's a quick impulse, right? It's kind of cool. They broke it down in these 3 different ways to quantify strain on the tendon. These were pain-free participants. So is this going to be exactly the same? Folks have pain? Who knows? I bet you it'd probably be less. These folks that have pain probably won't feel good loading the patellar tendon. So they may kind of stress shield by compensating, so on and so forth. So maybe not perfect, right? But pretty decent way of figuring out how much stress is going through the patellar tendon. And they looked at 35 different exercises. I'm not going to go super in depth into this just because I made a full video for it. I'll put a link in the show notes. You can check it out. But really briefly, they quantified strain on the patellar tendon into 3 different groups: tier 1, low stress; tier 2, moderate stress; and tier 3, high stress. Some of the things you saw in tier 1 were walking, low step up, 2-legged squats, partial range, and a low step down. In tier 2, they had exercises like a Bulgarian split squat, a full depth squat, a lunge, 2-leg forward hops, 2-leg forward hops maximally, a Spanish squat, running and stopping, 1-leg drop vertical jump. And then tier 3, this is the highest strain. You saw 1-leg maximal forward hop, 1-leg repeated forward hops, 1-leg counter movement jumps, running and cutting. And then the highest strain of any single movement that they studied, all 35 exercises, including all the jumping, including all the cutting, running, stopping, all that stuff, was the single leg squat on a decline slant board. So kind of my point earlier is that if you're starting your patients off with this exercise, you're starting them off with the most challenging movement we have studied to this point on the patellar tendon. So it just makes me laugh a little bit. Keep that in mind when you are dosing exercise. Again, I thought there's a really, really cool study. I made a whole video on it. So check that link in the show notes. Check it out. But yeah, you can use this study as a guideline for selecting movements. Any thought on this study before we move on, Kevin?
Yeah, I remember that Achilles tendon paper, but I didn't know that they came out with one for this. So I'll look more into that. I thought that's been really helpful. Just for kind of selecting like what's a early exercise I should focus on and then progressing. So yeah, good job by those authors. That's really cool.
Yeah, I mean, some of it's a little counterintuitive. Like I wouldn't have thought that's how you would progress some of these exercises, but I mean, that's what our research is showing. So it kind of challenged my biases a little bit. The other thing is, I think it's probably even more useful for those post-op patients, obviously post-op Achilles, because there's more of them, but post-op patellar tendon kind of repairs, right? I think the other one they mentioned in the study was post-op Achilles reconstruction with a patellar tendon graft. You can use these exercises kind of dose from low to high when those stakes are going to be a little bit higher, right? So those post-op patients is even more important that we dose appropriately. Whereas a non-op, we're a little less, conservative. We can be a little bit, a little more aggressive with our exercise selection, but maybe not with those post-op patients. Movement modification. Should we change the way our athletes jump? This is one of the things I covered a little bit more in depth in my last literature review. And I tell you what, there's been more research that has come out over the course of time, and it's gotten even more confusing, Kevin. So that's always good, right? I took this quote from a study paper. Lead author was Harris, Jump Landing Mechanics and Patellar Tendinopathy in Elite Youth Basketballers. And one statement I think really rang true with what I was reading and learning too. And I'll just read it directly from the study. Despite the voluminous literature, so much volume there, a large number of participants, a multitude of investigated parameters, and consistent research focused on landing biomechanics, only a few associations can be identified, such as reduced ankle dorsiflexion or plantarflexion range. Further, the quality of the existing literature is inadequate to draw strong conclusions, with only 4 high-quality papers being found. We were unable to determine biomechanical factors that predicted patellar tendon pain onset, as longitudinal/prospective studies enabling causal interference are absent. What this essentially means is if you're jumping and landing in a more quad dominant fashion, so when you land, you're basically kind of bringing the knees forward, flexing the knees more. Thought is maybe that's going to lead to more patellar tendon pain. Maybe we should be altering people's jumping and landing mechanics in order to reduce people getting patellar tendon pain in the future, or modifying that movement so that we can help to rehab them. I still think this is an interesting treatment idea, and we are always modifying movement in the gym to try to progress athletes. So one of the things you can do is retrain jumping. So have them land with their hips back, get a little more hip flexion on the landing as opposed to more knee flexion. And this may be a modification that helps with pain, but doesn't seem like there's a causal relationship in the literature overall. In some of the papers, you'll find that, some not so much. So a little confusing, but I think you see the same thing with like gait, like running gait. Does that lead to patellofemoral pain? Does that lead to IT band pain? Some studies show maybe yes, some maybe not. It's all over the place, so it's complicated. I recommend you read through some of this literature yourself if you can. Again, link in the show notes for all the references. But for patellar tendon pain, doesn't seem like it's a strong risk factor. Any thoughts on that, Kevin? Did you find anything different?
Yeah, I think what I use that type of information for is just understanding that there's probably no perfect way to land to reduce these stresses. But, you do see I think you see those more bouncy quad dominant athletes. Maybe they do have reduced ankle dorsiflexion, and the onset of pain is kind of related to how much knee flexion they're using as they're loading their quad. But then what I tend to see when it's really flared up is that they'll jump or step off a box, and they're really using a hip dominant strategy to avoid loading the knee once it's painful. And then, we do want to work on the mechanics a little bit, because I think this is just my opinion. I think their brain changes a little and they get used to jumping with this hip dominant strategy or landing with this hip dominant strategy because of the pain they're having. And based on the amount of time they're doing that, it becomes their like new norm. So I look at it more from a performance standpoint, is like, maybe they can optimize the way that they're landing. But we don't think about it as like, this is the avatar of the perfect landing mechanics. And, this is why you're having knee pain. But for the person in front of you, if you do feel like it's something that they're modifying because of the pain that they're having, it should be part of the treatment program to help them get back to the way they were, and maybe improve that if it's going to improve performance, is how I'll think about it.
Mm-hmm. And I think we talked about this a decent amount, and a little spoiler alert, because I just went through the literature on IT band, and we'll talk about the next podcast, right? Crazy. But one of the things you see quite a bit, and we went over this with patellofemoral pain, but when someone tries to do a step down task, they'll try to move more through the hip because the knee hurts, right? You used to think that, okay, you move through the hip, that's why you have knee pain. Now we're kind of finding, well, people probably move more through the hip because their knee hurts, right? And they're trying to use the hip a little bit more. You see that with patellar tendon pain, just like you're saying, Kevin. And in IT band pain, what happens with folks from that standpoint is as they progress into the run further and further, they generally run with a little less hip adduction. So the idea is that as they run further and that knee becomes a little more painful, they may actually run in a way to shield stress on that area. They limp, right? They're kind of limping. I call it limping. They're compensating. That makes sense. So movement changes due to pain. I think that's important. The physical therapists keep that in mind. It's not as simple as like, oh, the reason why you hurt is because you move this way. It's like, well, they might just move really differently because now they have pain. And maybe it was the way they moved before too. I think there's some relevance to that, but it's not the only piece of the puzzle. There's a lot of players there. So, and next, we already talked about this a little bit, but load management is going to be one way of helping to treat these folks. And in the progressive tendon loading paper, they use a pain monitoring model, which we've talked about extensively on this channel. In the pain monitoring model, essentially you can use all exercises that are 4 out of 10 or less. At least in this paper, for the progressive tendon loading, they use a 3 out of 10 as their kind of cutoff. And with the eccentrics group, it was 5 out of 10. And I don't know why. We should probably talk to the authors at some point, but maybe it's because single-legged decline squats are just painful, right? Also, they recommended modification of all athletic activities, right? Essentially, they cause greater than those numbers of pain. And they are also forced to either significantly reduce or avoid certain activities for at least 4 weeks at the start of rehab. So essentially, you continue all your sport activities within the limits of the acceptable pain parameters. And like I said, for the progressive tendon loading group, if you were doing your sport activities and it was less than a 3 out of 10 on a 0 to 10 scale, next day you're kind of back to your baseline, that's acceptable. So you can give your patient some guidance on which activities are okay and which ones to potentially avoid early on in therapy. Any thoughts on that before we move on, Kevin?
No, we can progress there.
Yeah, I think we've kind of beaten that dead horse. We hate animals, huh? I mean, if anything you learned,
a lot of animal abuse on this podcast. Yep.
I love animals, but I love those analogies. All right. How about additional treatments? We know that this is a recalcitrant condition in a lot of individuals. It's tough to treat. Can we have an effect? Yes. But are outcomes phenomenal? Not really. In that progressive tendon loading, even with the better treatment, we had a 43% success rate getting back to the level of prior injury, right? So are there other additional treatments that we can try other than just exercise? This study here was in the Journal of Bone and Joint Surgery 2022, and it was entitled Patellar Tendinopathy Critical Analysis Review of Current Non-Operative Treatments. And essentially, they graded different treatments on basically an A to Z scale. I don't think it went all the way to Z, but A is good, and then B, C obviously is worse and worse. And essentially, exercise was at the top, grade A evidence to show that it is an effective treatment for folks that have patellar tendinopathy. However, PRP injections had a grade B, and they can be beneficial for refractory cases. So essentially, those folks that tend not to do really well with exercise, maybe a PRP injection is the next step. There's also a bit of evidence for stem cell treatments, either bone marrow or mesenchymal stem cells. This is grade C evidence, so not as many high quality papers, and a little bit of evidence about hyaluronic injections having short-term effects. In terms of low-level laser, we actually use a high-powered laser at our clinic. I actually think it is pretty helpful for a lot of different tendon problems. There's insufficient or conflicting evidence for this. How about extracorporeal shockwave therapy for patellar tendinopathy? I tend to use a decent amount. Seems like the evidence is insufficient or conflicting, although I'll still give it a shot. Topical glycerol trinitrate. I didn't know much about this. I've never used it. They had grade 1 evidence for this. It stimulates healing. It's just something that goes over the patellar tendon. And the idea is that it stimulates a bit of healing. Never used it, but maybe an option to send it back to the physician. Hopefully they have an idea. Strapping. How about that patellar tendon strap that goes over the patellar tendon around the knee? So in the short term, can have a 25% reduction in pain, although it seems like there's no long-term benefit, right? And that kind of makes sense. We're not really changing the tendon structure or helping to heal that tendon, but it does seem to help with pain. And for a lot of folks early on, I'll say, yeah, give it a shot. If it works, keep using it, right? But it's probably not going to be that long-term solution. How about surgery? I think Lenny actually has a bilateral patellar tendon debridement patient right now. He seems to be doing pretty well. But what does the evidence show? Is it beneficial to get surgery if all these treatments fail? Yes, actually. It seems to be beneficial for refractory cases. Surgical intervention is considered after failure of non-operative treatments and typically occurs in tears greater than 50% of the tendon thickness and in tendons with increased tendon thickness, greater than 8.8 millimeters. So essentially, you're only doing this in patients that have either a pretty decent sized tear in their patellar tendon or a lot of tendinosis. And they actually have good return to sport rates. So that was actually pretty dang nice. To see that if your patient's not doing well, obviously these are recalcitrant, you can consider surgery, and they actually tend to do pretty well. And I don't see too many of these, but again, Lenny has one right now. He seems to be doing well, and he's actually a pro hockey player, I believe. So you do see these, and they tend to do pretty dang well. What are your thoughts there, Kevin? Are you doing trinitral glycerate, rubbing it all over that knee?
No, but I'm going to. Just going to be the triglycerate guy. Is that what it is? Yeah. Yeah, I think it's, we're kind of spoiled where we work. We have access to some of those things, and we're doing the grade A stuff anyway. So then, why not try some of these things if it seems like they might offer some benefit, if there's some conflicting evidence, where our patients are there for a certain amount of time. So, they can spend as much time as they want with us. So we can really try a bunch of things and see if it helps. But, obviously you want to start with that grade A and give that an honest shot for quite a while. I have a lady right now with a hamstring tendinopathy that's been going on for, probably 2 years or so. And, she's at the point where she had a recent flare up, kind of fed up. So we're referring her to one of our local biologics doctors. And, I think that consult could be very helpful for her. So I think if you've reached a point where the patient feels like they've really, and she's been so compliant, she does a good job, and then little things kind of set her back still. So, she's kind of at her wit's end and just looking for another treatment option. So, I think eventually, when you are beating a dead horse for so long, it is okay to try other things. We have some options here to try. And I will say, anecdotally as well, I think the strap I've seen some benefit with, like, people will say, hey, I bought this strap. Should I try it? And usually what I do is have them put it on and we'll try some exercises. And if they're like, whoa, that feels better, then yeah, totally wear it. That's fine. If we can get more loading with the strap on, you feel better doing some of your activities with it on, or you're in season, you could play because you're wearing it, then yeah, it's totally worth it. I think just be honest that it's not going to solve the issue long term, but if they want to try it, definitely try it. So that's kind of how I look at that.
Yeah, for sure. And I think just like anything else, if you're not making progress, you probably should refer back to a doc. You just have to have a doc that's good, that knows about these additional treatments, stays on top of the literature, maybe is a little more open-minded to some of the newer research coming out. I've been surprised sometimes. I've had patients that have pretty stubborn tendinopathies. They end up going back to the doctor. Turns out they had a calcific tendinopathy, which is a little more recalcitrant sometimes. Mm-hmm. And they do something like a 10X procedure, and the patient does really, really well. And I wouldn't have known that unless we sent to a doc to get some additional imaging and figure out those next steps. So because it's tendinopathy, Doesn't necessarily mean that you have no other options besides just exercise, which I think is sometimes the thought for physical therapists. I would say if you're not already, try to find a good physiatrist, someone who kind of specializes in things like orthobiologics, shockwave therapies, ancillary treatments, and then obviously a good surgeon as well, just because that's another good option if patients aren't progressing over the course of time. So, all right. So now you know all the basics about the evidence when it comes to patellar tendinopathy, but you still have no idea which exercises to choose for your patients. We just talked about how it's important to dose exercises, and I have a video that's going to show you exactly how, and it lives above Kevin's head. So Kevin, where's your head at? There it is. Go ahead and click on that link, and I'll go over how to dose exercises for patients that have patellar tendinopathy so you don't flare them up and you give them enough stress so they get back to the sport and they love you. Click on that link, and I'll see you there. If you're watching this on YouTube, please, please, please hit that like button. Consider subscribing to the channel if you enjoy this. If you're listening to the podcast version of this, please give me a 5 out of 5 rating. It helps tremendously. And lastly, if you want to go that next step and support me further, consider subscribing to Fitness Pain Free Insiders. So Insiders is like Netflix for physical therapists and coaches working with painful folks in the gym. You've got access to 100 plus webinars, ebooks, and courses. More recently, I've been taking all of my best content from YouTube. I've been taking out all the ads. I've been organizing it in a really step-by-step fashion in an entire course so you can easily go through it. And I add additional pieces to this to enhance your learning, right? So I just finished up my lateral ankle sprain course. And one of the big things I add to this was a protocol. So essentially, what do you do week 1, week 2, week 3, week 4, week 5, 6, 7, 8? You know me, I like working with athletes. I like working with really fit and strong people. So it's going to be a lot more robust than your typical protocol. Also, you have access to me. So inside of Insiders, you can leave a comment and I'll get right back to you. I also have physical therapy CEUs inside of Insiders. So if you take the course, Essential Coaches Series, get a bunch of CEUs. And what's even better is you can start for just $1. After that, it's $25 per month. It's going to be the cheapest CEUs you can get. It's by far the highest value program that I offer at the cheapest price. So head over to fitnesspainfree.com, click on the program's link, and then click on Fitness Pain Free Insiders to get started. I'll also leave a link in the show notes where you can check it out.